Considering the overview of the cervical spine, the C1, C2 and C7 vertebrae are regarded as being atypical because C1 does not have any vertebral body and has an anterior and posterior arch and anterior and posterior tubercle. C2 has an odontoid process and a bifid spinous process, and C7 is the transitional vertebra between the cervical and the thoracic spine and has the most prominent spinous process, which is known as the vertebra prominens. The lordosis of the cervical spine is about 20 to 40 degrees, and this changes to a thoracic kyphosis of approximately 20 to 40 degrees. The lamina of the vertebral body above overhangs the lamina of the vertebral body below. The ligamentum flavum arises from the edge of the lamina of the vertebral body below and also from its posterior superior aspect, and then gets attached to the edge of the lamina of the vertebral body above and also its anterior inferior aspect. That is why whenever a laminectomy is done, it is always done from an inferior to a superior aspect. The C1 nerve root emerges from above the posterior arch of the atlas. The C2 nerve root emerges from between the C1 and C2 vertebral bodies. The C3 nerve root emerges through the intervertebral foramina between C3 and C4 vertebral bodies, and so on for the caudal vertebrae. Likewise, the C8 nerve root emerges from between the C7 and T1 intervertebral foramina. The atlantoaxial region does not have any intervertebral foramina. The capaciousness of the C1, C2 space available in the region is responsible for the large extradural or dumbbell neurofibromas that grow to take a large area without causing neurological deficits. Boundaries of the intervertebral foramen at each level includes two contiguous vertebral bodies and their disc space anteriorly, forming the oncovertebral joint. The superior and inferior articular processes forming the zygapophyseal joint posteriorly, and the pedicles of the contiguous vertebrae forming the superior and inferior margins of the intervertebral foramina. The natural tendency of the oncovertebral joints and zygapophyseal joints to provide stability to the cervical spine occurs in the form of bony expansion into the intervertebral foramina as osteophytes that may cause radiculopathy, or into the cervical spinal canal causing myelopathy. The range of movement of the cervical spine is as follows: 80 to 90 degrees of flexion, 70 degrees of extension, and 90 degrees of external rotation. The flexion movement at the atlanto-occipital joint is around 10 degrees. At the atlanto-axial joint, it is about 5 degrees. And the subaxial spine has an intersegmental flow of flexion motion so that it compensates for rest of the flexion movement. When we look at extension, at the atlanto-occipital joint, 25 degrees of extension occurs. At the atlanto-axial joint, 10 degrees of flexion occurs. And in the subaxial spine, the rest of the extension occurs, with the maximum extension occurring at C5-6 level. The rotatory movement at the neck is limited by the capsular ligament of the facet joints. Out of 90 degrees of rotation to either side, nearly 45 degrees occurs at the atlanto-axial joint, and the rest occurs from C3 to C7. The lateral flexion is distributed from the C2 to C7 levels. The occipital condyles form an ellipsoid or a condylite joint with the kidney-shaped superior articular process on the superior surface of bilateral lateral masses of the atlas. This joint permits flexion and extension movements or the yes movements to occur at the neck. The inferior articular process on the inferior surface of lateral mass of the atlas forms a planar joint with the superior articular process of axis and allows the rotation of neck to occur or the no movements to occur. The lateral masses of the atlas form its strongest area. From the medial border of the two lateral masses, the transverse ligament, which is the horizontal part of the tectorial membrane, keeps the odontoid process in the pivot synovial joint with the posterior surface of the anterior arch of atlas. In case of transverse ligament incompetence, atlantoaxial dislocation occurs. An atlanto-dental interval of greater than 3 millimeters becomes significant. In Jefferson's fracture or the burst fracture of atlas, the sum of the lateral mass displacement greater than 8 millimeters means that there is transverse ligament incompetence. The anterior tubercle situated on the anterior arch of atlas is an important landmark. In transferal decompression, the palpation of the anterior tubercle and the two anterior facet joints gives a good idea of the midline even if there is a rotatory component present in the atlantoaxial dislocation. In lateral mass screw placement, the screw is directed medially and upwards 5 to 10 degrees, aiming for the anterior tubercle of the atlas. The foramen transversarium of the atlas with the vertebral artery is thus lateral to the trajectory. The lateral one-third of the superior surface of the posterior arch of the atlas harbors the groove for the vertebral artery after it emerges from the C1 foramen transversarium and before it becomes interdural. The C1-2 dissection should be confined to the space between the atlas and the axis and should not extend to the superior surface of the lateral one-third of the posterior arch of the atlas. This avoids injuring the vertebral artery. The inferior edge of the posterior arch of the atlas may be drilled to expose the lateral mass of atlas, especially when this is occipitalized and there is condylar hypoplasia. This is also very useful if ganglion preserving C1 C2 facet joint surgery is being performed, in which the screw placement above the C2 ganglion is facilitated by the complete exposure of the C1 lateral mass by the drilling of the posterior arch of C1. Considering the applied anatomy of the axis, the odontoid process is made of many ossification centers. So there will be intervening cortical bone between the trabecular bone, and this is evident on the MR imaging. So when we are drilling the odontoid, the assessment of the cortical bone in relation to the MRI sagittal images will give you a fairly good idea where you are with respect to the height of the odontoid. One important question which often arises is what is the difference between a pedicle and pars interarticularis in relation to the axis vertebra? The pedicle is the part of the bone which is present between the superior articular process and the body and odontoid process of the axis vertebra. The pars interarticularis is the part of the bone between the superior and inferior articular process. So therefore, if one has to put a pedicle screw, then one has to direct the screw at more angulation from a lateral to medial aspect. Whereas if one is going through the pars interarticularis, then one has to stay parallel to the medial border of pars interarticularis towards the C1 C2 joint. The foramen transversarium of the axis is located lateral to the facet joint as well as the pars interarticularis. So if one is following the medial border of the pars interarticularis in a direction which is about 15 to 20 degrees upwards and medially, then one is unlikely to encounter the vertebral artery unless the vertebral artery is placed posterior to the C1 C2 joint. One important thing that one should really take care of is a high riding vertebral artery which can actually indent through the inferior surface of the pars interarticularis and may be injured when the pedicle screw through or the pars interarticularis screw is being placed. In case a translaminar screw fixation is being performed through the lamina of axis, then the two screws are at different levels so that their profiles do not conflict with each other. the subaxial spine, the approximate transverse length of a vertebral body is between 22 and 25 millimeters, and the diameter of the spinal cord at the cervical level is approximately between 8 to 11 millimeters. So, in order to create the anterior gutter to decompress the thecal sac adequately, a gutter of at least 18 to 20 millimeters has to be created. As one can notice, the pedicle, which is the part between the superior articular process and the body of a subaxial vertebra, is very narrow and very close to the foramen transversarium. Therefore, it is much safer to do a lateral mass fixation. The trajectory of the screw in this case, in contrast to the axis and atlas vertebra, is directed laterally. The foramen transversarium of the subaxial cervical vertebra is located more medially as compared to their lateral masses, and therefore when the trajectory of the screw is directed laterally, then the screw tip is unlikely to injure the vertebral artery. The two ways in which vertebral artery can actually get injured are: number one, if one strays beyond the margin of the vertebral body towards the foramen transversarium, and especially if one is using monopolar forceps to dissect out the longus colli muscles on the two sides, then one can injure the vertebral artery. The second way in which the vertebral artery can be injured is by an oblique drilling of the vertebral body, and in this case the vertebral artery is likely to be injured not at the superior or inferior aspect of the vertebral body, but rather in the middle part of the vertebral body as the drill breaches the foramen transversarium. While doing a laminectomy and a foraminotomy of the cervical spine, one has to be very careful that not more than 1/3 of this articular process is drilled and removed. Otherwise, one is likely to destabilize the cervical spine and a fusion might be required. The unique features of the C7 vertebra include a prominent spinous process. Usually, the pedicle and lateral mass is very thin, so that transpedicular or lateral mass screw fixation may not be possible. The transverse foramen of C7 does not contain the vertebral artery which skirts along it. Occasionally, an extra cervical rib may also arise from this junctional vertebra. The final point I would like to make is regarding the vertebral artery at the level of C1 and C2. The foramen transversarium of C1 and C2 are placed more laterally as compared to the subaxial spine, and this provides laxity to the vertebral artery to permit neck movements. So, in the region of the neck, turning the neck to one side by 45 degrees compromises one vertebral artery, and turning it to 90 degrees compromises both vertebral arteries. I'm grateful to you for your kind attention.